Dear colleagues, this is another soft cataract done on subconscious anesthesia. This is a case of closed-angle glaucoma young patient that opted to do the cataract surgery mostly for refractive purposes. It's very soft nucleus, and I done this case with the Constellation machine. The capsular axis is fashioned with the 25 gauge grease saber forceps, and I'm trying to centrate it a little bit on the visual axis rather than the middle of the eye. And I leave it to run a little bit towards the periphery to enlarge it in the nasal part of the eye. The capsular axis is complete. I do the hydrodissection, hydrodelineation also, and this is a very small nucleus having the golden ring, enlarging the paracentesis and placing the viscoelastic inside the anterior chamber, and using the phaco machine, the Constellation, I do a horizontal chop on this case. The nucleus is extremely soft and mushy, but we still are able to crack the nucleus into two heminucleuses, and the core part of the nucleus, the small nucleus, is aspirated very easy out of the bag, and then the other half of the nucleus, it's coming out pretty easy, the epinucleus. In this case, I'm gonna use trifocal IOL from Zeiss, and it's pretty much phaco aspiration. You don't use any ultrasound in these cases, since it's very soft cataract young patient. Most of the viscoelastic is still in the anterior chamber at the end of the phaco aspiration. Try to aspirate a little bit the cortex from the bag, and then using the safer instrument to use in this cortical aspiration, placing the AC maintainer and using the aspiration needle. It's a safer way to take out the cortex out of the bag. It's very important on these young patients to have a clean bag and aspirate the cortex real well, and even the anterior capsule to be polished a little bit to avoid phimosis of that capsule. You notice that there are still viscoelastic left in the anterior chamber, which is not a bad thing. And finishing up the cortical removal, injecting the trifocal IOL inside the bag. It's a very easy job to do. Using the chopper, I'm able to push it back inside the bag and the trailing haptic, and then rotate the IOL into the position and make sure it's well centrated. You're gonna see the rings immediately, and then cleaning up the anterior chamber for the viscoelastic, placing the myocolon air bubble, and at the end of the case I'm making a subconj injection with anti-inflammatory and antibiotic agent. Thank you for your attention. I hope this will help.